Okay, we're going to talk about the peripheral nervous system. Just 26 more slides. We've talked about the central nervous system. Now we're going to talk about anything that comes out of the central nervous system and diseases that affect those areas. So the peripheral nerve disorders are represented clinically by a group of signs called or known as neuropathic syndrome. The syndrome is commonly associated with trauma to the peripheral or even sometimes the cranial nerves. Signs of this syndrome include reduced or absent muscle tone. So we'll see reduced muscle tone, which will lead to atrophy of the muscles, weakness, paresis, or paralysis of the limb or facial muscles, followed in 1 to 2 weeks by neurogenic muscle atrophy. So if we don't use the muscles, we will lose the muscles. Peripheral neuropathies may involve a single nerve, such as a peroneal, radial, or facial nerve, or multiple nerves, as in polyradiculoneuritis, which we will discuss, and the cause of the neuropathy is often unknown. Deafness in animals is a peripheral nervous system disorder. This may be of central origin and results from damage to the CNS and auditory pathways, or it could be peripheral, resulting from cochlear abnormalities. So if you remember the cochlea that we talked about in the special sense organs, that is a very complicated organ, and it has very specific needs. And if it's abnormal at all, we're going to have some problems with hearing. Conductive deafness, which is usually a result of chronic otitis, rupture of the tympanic membrane, or damage to the middle ear, is common in animals. So conductive deafness refers to the loss of the ability of the animal to convert those vibrations of air into a nervous stimulus, as opposed to those that are central or peripheral in origin, because we've got damage to the central nervous system, the auditory pathways, or cochlear abnormalities. So it's like primary versus acquired. Neural deafness, or deafness based on the nerves, can be hereditary or congenital, meaning it's not hereditary, but they're born with it because there have been the animal or the mother that they were born from was either treated with something and it did some damage while they were being formed in the womb. Now, we can also get neural deafness due to drug therapy. There are certainly certain medications that will damage the nerves, or and it can be a normal aging change. Deafness appears to be hereditary in bull terriers, Dobermans, Rottweilers, pointers, blue-eyed white cats, Dalmatians, Australian heelers, English setters, Catahoula dogs, and Australian shepherds. Animals with congenital deafness suffer from partial or total agenesis of the hearing organ, the organ of Corti, the spiral ganglion, and or the cochlear nuclei. So any of those things being damaged can cause partial or total deafness. Drugs that commonly result in ototoxicity include the aminoglycosides such as, or for example, gentamicin, streptomycin, kanamycin, amikacin. Those are all aminoglycosides. There's also topical polymyxin B, chloramphenicol, and chlorhexidine with cetramide. Now, a lot of these are drugs that we use to treat otitis externa. So it's really important that we make sure that that tympanic membrane is intact and we keep those drugs out of the inner ear. Hearing impairment is normal in aging pets and is usually related to the atrophy of those nerve ganglia or cochlear hair cells that help to conduct or to convert the movement of air into a nerve stimulus. Clinical signs. So obviously a lack of response to auditory stimuli. They're excessively sleeping because nothing arouses them, or it's a breed that is prone to deafness. Diagnosis, partial loss of hearing and even unilateral, one side, complete loss of hearing is difficult to establish on a clinical examination of dogs and cats because they can often often hide that. They can compensate for that. An inability to arouse a sleeping patient with a loud noise is diagnostic. Behavior evaluation. So we can stimulate the animal with various sounds from different directions and evaluate the response. Often I will click my fingers around the dog's head, trying not to make an air movement, but trying to make a sound and seeing how they turn their head. Also, a physical examination of the external ear canals and tympanic membrane can assist with reaching a diagnosis. There is an electrodiagnostic way of testing. It usually requires referral to a specialty clinic, and testing can be costly. There's also tympanometry, which is when a probe is inserted into the ear canal and seals the canal. Sound and pressure changes are then delivered through that probe, and the tympanic membrane compliance measurements will allow the specialist to determine whether the ossicles and or the tympanic membrane are abnormal. And often these things need to be done when the animal is sleeping. Acoustic reflex testing is the delivery of increasing sound pressure levels to the ear, which evokes the acoustic reflex. Muscles of the middle ear contract to dampen the sound response and prevent damage. If the reflex is present, then the auditory system is probably intact. And the last one is an auditory evoked response. This is when cochlear function can be assessed by measuring brain electrical responses to air conducted clicks, either from a probe placed in the external ear canal or from a bone vibrator placed firmly against the mastoid process of the temporal bone. This is especially effective in detecting hereditary and senile deafness. Puppies and kittens should be at least 6 weeks of age for this test to be valid. I remember as a student at OSU, we would have litters of puppies, and litters usually it was puppies. Breeders would pay for this test to make sure that they didn't have any puppies that were deaf. And the puppies would be anesthetized. They would have this contraption put on their head, and their brain levels would be measured while they were asleep as the brain responded to clicking. No treatment is available for deafness in most cases. Loss of hearing is permanent. Hearing aids are available for animals. They do not look like this. They look like this, and they're like they can do these cochlear type implants. Okay. Many animals will not tolerate a hearing aid in the ear canal. They'll shake their head, they'll scratch at the ear. Because hearing aids are expensive, owners are advised to experiment with foam rubber earplugs in the animal's ear canal before spending money on an actual hearing aid. If animals will not tolerate the earplugs, it will not tolerate the hearing aid. Hearing loss is permanent. These animals are at risk for injury in their environment, especially in traffic, and they may bite when startled. If the deafness is hereditary, we do not want to breed the animal, but animals don't rely on their hearing as much as their smell, or dogs especially. So they can be taught to respond to hand signals rather than voice commands. But you can remember they should never be off leash when outside because we cannot recall them. Animals, we want to keep animals' ears clean and free of infection to avoid damage to the middle and inner ear, and it will help to maintain any hearing they might actually have. Hearing aids do exist for dogs, but they are expensive and a lot of animals won't tolerate them. Metabolic neuropathy. There are cases of polyneuropathy that have been reported in dogs and cats with diabetes mellitus, in dogs with hyperadrenocorticism, which is Cushing's disease, and in dogs with hypothyroidism. Clinical signs are variable from progressive weakness to muscle atrophy and decreased spinal reflexes. They can get paresis, paralysis, or even both. Hypothyroid dogs show signs related to cranial nerves, so they'll have a head tilt, facial paralysis, strabismus, and nystagmus encircling, and often with hypothyroid dogs we'll get a atrophy of the temporal muscle, which is due to a neurogenic weakness of that muscle. So hypothyroid dogs do show neurologic deficits. Good control of the underlying disease is required to limit neurologic damage. So metabolic neuropathy will occur with endocrine disease, diabetes mellitus, Cushing's disease, and hypothyroidism. Clinical signs will be varied. Of course, it depends on the underlying disease, and we can diagnose that through biochemical testing. We want to rule out all other causes of neuropathy. Treat that underlying disease and tell the client that we need to control that underlying disease in order to control the neuropathy. It can be controlled with proper medication, frequent reevaluation. And it's going to be a lifelong treatment. Laryngeal paralysis. It's also called LARPAR because laryngeal paralysis is hard to say. It is hereditary. It is acquired. And there can be also, or there can be hereditary, acquired, and idiopathic. We have no idea why this laryngeal paralysis can occur in dogs and cats. There is the hereditary form. We see these in Bouvier de Flanders. Those are big, hairy dogs, and in young Siberian Huskies. Acquired laryngeal paralysis can occur from lead poisoning, rabies, trauma, and inflammatory infiltrates of the vagus nerve. So remember, the vagus nerve innervates that larynx. And that larynx, what happens with laryngeal paralysis? Well, remember that larynx supports the start of the trachea and all of those connective tissue that help to close up the trachea when the animal is swallowing. If they close up the trachea when the animal is swallowing and then become paralyzed in that location, then we have a problem. So when we're examining an animal with suspected laryngeal paralysis, we also have to remember that rabies is increasing in incidence, and rabies can cause this laryngeal paralysis. The idiopathic form of laryngeal paralysis has been reported in middle-aged to old, large, and giant breed dogs, and in castrated male dogs and cats that appear to be more frequently affected than female non-neutered animals. There is a YouTube video that I'm going to post on your eLearn so that you can hear what it sounds like and see what the dog looks like when they're struggling to breathe, because those arytenoid cartilage and the vocal cords are blocking the airway. So hereditary clinical signs will be seen at 4 to 6 months of age, and for acquired, anywhere from 1.5 to 13 years of age. We will see inspiratory stridor. What is that? That is difficulty breathing in. What you will hear is a and you'll hear that on the video. We'll see respiratory distress. We'll see loss of endurance, a voice change. When you have laryngitis, you have a voice change. Dyspnea, cyanosis. They'll be blue because they can't get oxygen. And then a complete respiratory collapse. Laryngoscopy, so if we stick a camera down there, we'll see that the laryngeal abductor will not abduct those tissues away from the trachea, and it'll be a dysfunction that you will see. We can surgically correct this with arytenoidectomy, so we can actually remove arytenoid from one side. We can even remove it from both sides, but that does leave things open and possible aspiration pneumonia. Arytenoid lateralization, when we actually do a tie back, we suture it and allow it to scar back. We can remove the vocal folds as well. Information prognosis is guarded to good. We do not want to breed animals that acquire hereditary or have a hereditary laryngeal paralysis. Here are the arytenoids. These normally should open and close, and you will see this as you start to put trach tubes in animals. Here's the epiglottis pulled down. Here is the arytenoid that has been tied back. You can actually see there's a little kink in it where the tie-back surgery occurred. Laryngeal paralysis, or LARPAR, occurs in horses as well. And in horses, it's called roarers, roaring disease, because these animals, because they're so big, it sounds like they're roaring like a lion. And they do a similar thing with these guys. Tick paralysis, it's a neuropathy. In the United States, we have a common dog tick. It's called Dermacentor variabilis, and the Rocky Mountain wood tick, which is Dermacentor andersoni, are most often involved with a flaccid, afebrile, ascending motor paralysis. That means it starts in the back and goes to the front. So flaccid means it's flabby, it's weak. Afebrile means they don't have a fever. Okay, a lot of tick-borne diseases cause an intermittent fever. Cats appear to be resistant to tick paralysis. The female tick produces a salivary neurotoxin that interferes with acetylcholine, and we know that acetylcholine is important for stimulation of the muscles. So it interferes with those concentrations at the neuromuscular junction. The onset of clinical signs is gradual, and it begins with incoordination of the pelvic limbs, and it goes up to the thoracic limbs. Altered voice and dysphagia can be seen as it travels upward. Within 24 to 72 hours, the dogs become recumbent. They go down and they don't get back up. Reflexes are lost while sensation remains, and death can occur because of respiratory paralysis. Recovery occurs within 1 to 3 days after removal of all ticks on the animal. and the animals with respiratory involvement will need to be ventilated until those signs subside. So as long as the tick is on the animal, they are producing that neurotoxin and interfering with acetylcholine. And aren't you glad that you know about acetylcholine and about the nervous system and how it works with the muscular system, because now you know what causes this tick paralysis. Clinical signs: gradual development of hind limb incoordination progresses to a flaccid ascending paralysis. Diagnosis: we see presence of ticks on the dogs, and we can rule out the other cause of neuromuscular disease, but the first thing is take off the ticks. We can do it manually. We can use a dip. There's a dip called Proban. They can be used to remove any hidden ticks. We also need to do supportive care. If these guys are paralyzed, having trouble breathing, we need to support that. There is something else called coon-hound paralysis. It's also referred to as polyradicular neuritis because it affects many peripheral nerves. It is kind of interesting to us because it resembles Guillain-Barré syndrome in humans, which is a strange neuropathic disease that causes either intense pain or paralysis. And like the human syndrome, it could have an immunologic pathogenesis. So it starts because the immune system has been enraged somehow. It's become a little bit more active. But the exact agent has not yet been isolated. Many, but not all cases of CHP involve a raccoon bite before the development of clinical signs. So we see this in animals that like coonhounds that hunt raccoons. Recent reports indicate that raccoon saliva contains an etiologic factor for CHP, but only certain susceptible dogs are at risk for acquiring CHP. Pathologic findings: so if they die and we do a necropsy, we'll see a segmental demyelination. So they'll lose the myelin sheath, that covering over the nerve roots, and we'll see degeneration of myelin and axons, and especially at those ventral nerve roots, which is the motor, right? The motor nerve roots are the ventral nerve roots. Disease affects adult dogs of any breed, either sex. Clinical signs appear within 7 to 14 days after exposure to the raccoon, although some dogs experience development of disease without exposure to a raccoon bite. Weakness begins in the hind limbs with paralysis, progressing rapidly to a flaccid systemic tetraplegia. Some dogs may be more severely affected. In severely affected animals, there may be an absence of spinal reflexes, loss of voice, labored breathing, and an inability to lift the head. These animals may die of respiratory paralysis, and paralysis can last 2 to 3 months, but the prognosis is generally good for most cases if we can get them past this. Clinical signs: recent exposure to raccoon or some other nonspecific antigen stimulation. They've had a severe infection. Ascending flaccid paralysis, we have an alert afebrile animal. So, and we make sure there are no ticks on them, right? Clinical signs will have lower motor neuron signs, which is just a way of doing some signs that we see from the neurologic exam. We'll discuss later. We'll have a history of some antigenic stimulation, and we want to rule out all other metabolic or infectious causes. Treatment: supportive nursing care. Steroids in anti-inflammatory doses have been used clinically. We need to support the respiration if necessary. Animals can develop this condition without exposure to raccoons. Affected animals may require long-term nursing care. Some animals regain total function, but severely infected animals may not. This is what facial nerve paralysis looks like. This is also called Horner syndrome. It can be idiopathic, acute facial nerve paralysis reported in adult dogs and cats. Hypothyroidism might be a contributing factor. It's damage to cranial nerves during oral. We can also have damage to cranial nerves if we're doing oral, like around the ears, or facial surgery, or with a traumatic endotracheal intubation during anesthesia preparation. Wait, what did I say? Yes, you can cause it. If you intubate traumatically in that area, that's where the cranial nerves are. And so you need to be very careful when you're placing that trach tube. Cocker Spaniels, Pembroke, Welsh Corgis, Boxers, English Setters, and domestic long-haired cats are predisposed to facial nerve paralysis. Biopsies of affected facial nerves show degeneration of myelinated fibers, The prognosis for a complete recovery is guarded, and so we need to do some nursing care for these animals. They tend to get an ear droop, lip paralysis. There'll be sialosis. They will be tearing and drooling. Deviation of the nose to the side because they no longer have muscles contracted on one side and contracted equally on both sides, so that they're relaxed on one side, so the nose will point in that direction. We will have collection of food in the paralyzed side of the mouth, and an absence of menace and palpebral reflex. A menace reflex is when you're menacing as if you're going to strike the animal, which puppies unfortunately need to learn that, and so they'll blink. A palpebral reflex will be when you're actually touching the eyelids and they blink. We can do electrodiagnostic testing of facial nerves, so we can actually put a probe on those nerves and see if they stimulate a reaction. Clinical signs of acute facial paralysis without any signs of trauma can help us diagnose this. Corticosteroids can be provided. We don't know if they really work or not. We symptomatically need to treat them. We need to provide artificial tears because if they can't blink, they can't spread tears over the cornea and keep it moist. We need to keep that cornea moist or we're going to lose the eye. We want to keep the oral cavity clear of food to prevent dental disease. Often the cause of facial nerve paralysis is unknown. Complete recovery does not usually occur. Animals can experience development of keratoconjunctivitis sicca, which is dry eye, because of damage to the nerves that pass to the lacrimal gland. Affected animals may require lifelong maintenance care, so we're going to be constantly lubricating that eye. All right, so a neurologic examination. I'm going to put this, it says on Angel, that's a long time ago. We're going to put this on your eLearn course shell, which will tell you what nerves to look at and what you should be doing. You want to take your time. You want to test each portion, mark abnormalities and normalities. You want to use the standardized form so you're not missing anything. And then we can make conclusions about the what the data is telling us. So I'm going to include these links on your eLearn so you can look through this and watch a neurologic examination. We can even do one in class. So bring your neurologic examination papers to class and we will do one on an animal and I'll show you how to do it. It sounds really hard. There's a lot of steps that you need to do. It's actually not that hard. You just need to take your time and go through each area. All right, I believe that's all we have except for your questions. Please bring them to class.